retinopathy. As Dr. Ajit Babu said, this is not exclusively for retina specialists anymore. With the number of diabetic patients around, it's every single ophthalmologist has to play a role in the management of diabetic retinopathy. We all know this number. This International Diabetes Federation, which brought out, showed that the prevalence of diabetes was 537. Earlier, we were looking at it as 467, and the recent data shows the number is quite high, which means we are facing with a lot of diabetic population in the world, more so in a country like India. This was a study done, a multi-centric study called Alternate India study, where we looked at the prevalence of diabetic retinopathy among the population, both in the urban and local area, and this was done across 10 states in India, across India, which showed that the overall prevalence of diabetic retinopathy above the age of 40 was around 12.5%. More importantly, it showed that the sight-threatening retinopathy was 4%, which is really, really huge. We are losing patients to diabetic retinopathy at a much faster rate than we can manage. So I'm going to restrict my talk to the systemic parameters, briefly touching on this. We know that there are quite a few systemic factors, the more non-modifiable are pregnancy, puberty, modifiable factors such as hyperglycemia, hypertension, dyslipidemia, obesity, and there are various other factors. And there are enough evidence to show that these are the risk factors which affect the progression of diabetic retinopathy. So to focus on this and how do we manage this? Duration of diabetic retinopathy is one important. The WestTR, the Wisconsin Epidemiological Study, had already shown quite some time back that duration is the strongest predictor of the development and progression of DR. So if you see the duration of diabetes more than 20 years, the chance of developing any retinopathy is 80% in spite of going a good diabetic control. Gender, they say male proportionately has a higher prevalence of diabetic retinopathy than women. Prevalence of diabetic retinopathy, including the sight-threatening or the vision-threatening diabetic retinopathy, increases with the age. As we know, the duration is a important factor. And earlier it was thought it was much higher in the urban population, but it was seen in this study done by all of us that this is similar both in the urban and in the rural population. Unfortunately, in the rural population, we do not have access to care for many patients. There is the lack of ophthalmologists in this area. So these are because they're mostly concentrated in the urban areas. So we have to realize that this prevalence is much higher, be it if the patient is from the urban or even in the rural areas. One important factor, we all know that glycemia is a very important risk factor for diabetic retinopathy progression. In spite of intensive glycemic control, it has been shown that the progression of diabetic retinopathy is markedly reduced when compared to the standard treatment or standard management of glycemia. And more importantly, it is found to have a persistent effect on diabetic retinopathy progression, wherein the prior intensive control continues to have late benefits even after years of withdrawal of intensive control. The earlier you institute the intensive diabetic control, the earlier you prevent any advanced stages of diabetic retinopathy coming in. The Chennai Urban Rural study done by the Mohans Diabetic Center showed that every 2% elevation in HbA1c, the risk of diabetic retinopathy is increased by a factor of 1.71. As it said, there are enough trials, clinical trials, which have shown that the microvascular changes is markedly reduced as far as the microvascular changes as in the eye and in nephropathy is markedly reduced. In macrovascular changes, there is a moderate role in controlling the diabetic, the glycemic control. This was another study done by the Mohan's group, which said to assess the relationship between the regularity of follow-up and the risk of complications in patients with type 2 diabetes. They were followed for up to 9 years at a tertiary center, and they found that in patients with type 2 diabetes, regular follow-up was associated with significant lower glycemic burden and lower incidence of retinopathy and nephropathy over this 9-year period. So it clearly showed that following up these patients very closely helped in reducing the chances of damaging the retina or the kidneys. Blood pressure control, of course, we all know that it also plays a major role in the progression of diabetic retinopathy. The better you control, there are enough evidences to show that. Another important factor is the risk factor is the serum lipids. When there is a lot of hard oxidates associated, especially in diabetic macular edema, high serum total cholesterol is associated with higher prevalence of hard oxidates in both younger and older onset group patients. And higher level of serum lipids were associated with increased risk of hard oxidates in the macula. Dr. Amod Gupta from PGI had clearly shown that the controlling this lipids helps in reducing the hard oxidates in the macular area, where oral atorvastatin therapy in patients with type 2 diabetes with dyslipidemia reduces the severity of hard oxidates and subfoveal lipid migration in the patients with diabetic macular edema. What about kidneys? We know both the vascular changes, the microvascular changes that affects the retina. The same problem happens even in the kidneys. They are with patients with microalbuminuria around 2 times as likely to have diabetic retinopathy as those without microalbuminuria. And then in the presence of macroalbuminuria, the risk is almost 6 times. Diabetic kidney disease at baseline is another important risk factor for the progression to sight-threatening. Patients who have diabetic kidney disease are likely to have advanced diabetic retinopathy or vision-threatening retinopathy. Pregnancy, as we know, is a definitely a risk factor, especially pregnancy in patients who are known diabetics. They have to be extra careful because of the high levels of estrogen and other hormones that increase during this period can cause the progression of retinopathy. And it's been noticed that diabetic patients who are becoming pregnant are more likely to develop diabetic retinopathy and progression compared to people of the same age without diabetes. But in a women who begin a pregnancy with no evidence of retinopathy, the risk of developing diabetic retinopathy is about 10%. And it is important that these diabetic women should be counseled regarding the effect of pregnancy on retinopathy, as we know that those who have diabetic changes, especially advanced diabetic changes like sight-threatening or vision-threatening or severe NPDR, should be treated first before they even go into conception. They should be warned about that, and they should be examined very closely in their first trimester of pregnancy. Anemia is another important factor where the diabetic retinopathy can worsen. Anemia can lead to, if you have a low HbA1c levels with low anemia, because with anemia the patients are likely to be missed, and so you have to make sure you check the hemoglobin levels of these patients and then only take in the HbA1c levels for further assessment. So we know that anemia is an independent risk factor, can cause damage, and by correcting that, you can improve the diabetic retinopathy status. Another condition, that impact of diabetic retinopathy and cardiac outcome on coronary patients who are undergoing CAPG, the overall presence of retinopathy is definitely a strong risk factor for all-cause mortality for patients undergoing CAPG. The 12-year overall survival rate has been shown as only 40% in diabetics with retinopathy, while in those without retinopathy it is 80%. So we did a study here at Arvind to look at this with one of the cardiologists to assess the impact of diabetic retinopathy on the cardiac outcome after coronary artery bypass. So these patients, about 126 patients, were observed over a period of time. Their baseline retinopathy or diabetic retinal status was measured and was clearly seen in those patients with retinopathy. The non-fatal myocardial infarction or the congestive heart failure was much higher in relation to patients who did not have retinopathy at baseline when they did the CAPG. So they had adverse events, and the 18-month follow-up of our study showed that advanced cardiac events were reported in 65% of the patients who had diabetic retinopathy. So what is important is how well are these patients controlled in our study. Today we have a very poor control. The reason is, one, we all focus on diabetic retinopathy as a condition, but how much do we look at the systemic status of the patient? It is important that every ophthalmologist talks to the diabetologist, their physicians or diabetologists, to ensure that their patients that they are treating is well controlled for all these risk factors as they continue the treatment. Otherwise, your prognosis is going to be very poor. Thank you.
Thank you, Dr. Kim.